We'll give it another 30-ish seconds on my end. And yeah, as you should see, a poll just popped up. If you could go ahead and fill that out, that would be awesome to give me some idea of who you all are. And also drop in the chat what year you are in whatever program. So poll plus chat, please. Okay, we'll give it 30 more seconds just for people to fill stuff out. If you're watching on the YouTube or recording, you can go ahead and skip like 20 seconds of me just staring here looking at you. Nice to meet you, Rachel. All right, we're gonna get rolling. Please keep filling out the poll, putting in chat and all that. And I also want to direct you to the Q&A feature that is on here. That is going to be the best way to ask questions. That way I can directly reply and all of that. There's going to be plenty of Q&A time. So just to be aware of that feature. Chat is great. If you want to direct message the lovely Sketchy marketing team or Noelle, who is in here helping run this webinar, you can do that for technical support, things, all of that. Any questions about content and all that, would love if you could put them in the Q&A portion. That way I can handle it once we are done screen sharing and all that. And so I'm gonna keep this pulled up on the left side. And just getting a confirmation if no one speaks out or anything like that, you don't see any weird fuzzy boxes on the left side that's blocking any of the screens. Everything should look okay if I'm doing this correctly. All right, someone would have told me if it was wrong. So we're going to get going. Welcome, everyone. I appreciate you being here. My name is Connor. This MD after my name is very new, as of like a couple weeks ago. So I call myself like honestly, MS like 4.1 or MS5, whatever you want to call it. I haven't even started residency yet. So I'm still a med student-ish, although technically I have a degree. I've been working with Sketchy for like 4 years now, and it's one of my favorite things that I get to do. Obviously, wouldn't be doing this if I didn't love them. So I went to University of California, Irvine in Southern California. I'm soon to be an emergency medicine resident up in Northern California. And trust me, IM and EM are very similar, so we can talk about this. Thank you for all the congrats in chat. I appreciate you guys. And then when I did IM, something that was really important to me. So we do half our time at the VA and half our time at our home institution. And at the VA, at our home institution, it's very consult heavy. You kind of, if, for example, if there's a new heart failure patient or something, you have to friendly consult cardiology so they are aware. At the VA, it's completely opposite. And so I had a wonderful attending for 2 of the 3 weeks who essentially said that I'm an internal medicine doctor. I know when I need to consult people and how to ask for help. But if I can't manage new onset heart failure or liver failure or anything, then what am I doing as an internal medicine doctor? So that to me was a really great takeaway of not like some crazy story or anything, of just how talented the internal medicine physicians are. Sometimes, yes, you need consults, but they can get away with not consulting a large period at a time. So what we're going to talk about is the internal medicine rotation. And you can kind of apply this to a whole bunch of other stuff as well. And again, at any point, drop questions in the Q&A. I will answer them all at the end, I promise. And then we'll go over some sketchy internal medicine stuff, the Q&A, and then there's a wonderful giveaway for a 6-month subscription at the end of this, and a 25% off discount, which is pretty good. There's no discount higher than that right now. So it's pretty darn good if you haven't purchased already. Okay, so internal medicine. I will note it's been about 1.5 years since I did internal medicine. That being said, I have to do 2 weeks of awards this year. So your basic expectations on internal medicine. So this is going to be quote unquote your bread and butter medicine. You're going to see heart stuff, lung stuff, liver stuff, brain stuff. You're going to see everything. You're going to see a lot of social issues too. These are patients that probably could have been discharged a couple of weeks ago, but for some reason are stuck in the hospital because of insurance. They can't find a care home. They don't have a caretaker at their own house. So a lot of social issues, really, we see it a lot in the emergency department, but in internal medicine, you're really faced with dealing with those social issues, which is something I never truly realized until I did it. Your big focus in internal medicine is going to be your history taking, your exam, and then what do you want to do? That's a question that gets asked all the time, and something as a third or fourth year med student or PA student or NP, whatever year, what you want to do is kind of you flexing your knowledge. And so we're going to really we'll talk about that in a bit more detail. There's going to be some team-based approach to care. You need assistants. You need your nurses. You need your consulting teams. You need the night shift team to help you out. So it's a really team-based approach. We do a lot of rounding, or they do a lot of rounding. It's a variety of different ways, and we'll kind of talk about rounding. And then really this is where you get into the meat of applying what you already knew. So for example, MS1 and MS2, you learn all the basic stuff, bugs, drugs, pathology, blah, blah, blah. This is now, you need to figure out what is going on with your patient, because sometimes me in the emergency department will have an idea and I know they need to get admitted, but I won't have it down 100%. So it's your time to kind of figure out what is going on. And then again, what do you want to do about it? So what is your role as a medical student, a PA student, anything, a student in the hospital? Get there early. So most teams that I've seen will get there around 6 a.m. That's when sign out is. I had days where they had me come at 7 because the first hour wasn't super important. I've also had teams that wanted me there at 5:45. So I always recommend 15 minutes earlier than whatever your team tells you. So make sure you ask your team when you should be there. This next thing, I don't know if you can see my cursor, but bullet number 2 is by and large what I feel like the most important thing of the day is. Now, everyone's going to say presenting to your attending, but I truly think part 2, right here, the pre-rounding portion is the most important stuff. So you need to review a lot of data in the morning, and you need to do this efficiently. So you're going to look at, you're going to look at previous notes. So go back to the other med student, to the resident, whoever wrote a note on that patient yesterday, and see what they wrote and what the attending co-signed. What did the attending say? Because that's the verbiage you want to carry over. Nursing notes are great for overnight, figuring out what happened to your patient overnight. Were they chilling? Did they sleep? Or were they up all night and required some sedatives? Again, tons of information there. Your vitals are vital, as well as ins and out. Are they peeing? Are they pooping? Are they eating? I kind of care a lot about that, because if you're not eating and not using the restroom, I can't really send you home safely. And then all the other stuff, labs, imaging, pathology, micro, see if there were daily labs, see if anything, that cancer screening popped up from 4 days ago, review all of this type of stuff. You should come up with a systematic way to do this. And again, we're going to talk in one of the later slides about pre-rounding. You're going to then, after this, you're going to see and examine your patient, do a physical exam. I hate this part of medicine. I hate waking patients up. You're probably going to have to wake some of them up. Some of them are probably going to be asleep. Some of them are probably going to have to wake up. I'm sorry. It sucks. It's kind of like a med student rite of passage, but I hate it. So you're then, after you do this, you're going to discuss with your team. This is probably your residents, and come up with a care plan. You might have a rough sketch of a care plan from the day before, or from up to date, or from AMBOSS or whatever, but you really want to run your care plan by your residents if you can, so you have an idea of what is actually feasible. You'll learn about all these cool tests and whatnot in the pre-clerkship years of school. We don't order them all the time. So you may throw something out of like, oh, I want to screen for X, Y, and Z, but that test might cost like $10,000. So you just have to be aware of that. Then what everyone is most afraid of is presenting to the attending. Again, we're going to talk more about that. But then you're going to present the patient what you want to do, probably in front of the patient, which is also scary, to the attending. Come back in the afternoon or whenever, finish your notes. You're going to speak with ancillary staff. You're going to call consults. And then you should always, 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 always see your patient again. You will never have enough patients where you're too busy to see them. So you should do what I call afternoon rounds and go see your patient or patients in the afternoon. See how they're doing. Sit and talk to them. Watch TV with them. You have time to do that. That's good patient care. So more, oh my God, I went backwards. I'm sorry. More on your role. In general, you're not expected to memorize patient labs. I'm sure there is the one-off attending here or there that wants you to memorize that. Now, if they have a hemoglobin of 4, you should probably know that. Do I care if it's 4.1 versus 4.2? Probably not. But you should know the basics, right? But you're not expected to list off their sodium, their potassium, their whole CBC, everything like that. You're not expected to do that. So don't freak out about that. You should present in a logical order, but more importantly, be honest and consistent. Honesty is the most important part during your clerkships. If you didn't mash on their belly in the morning and now they're complaining of belly pain, you got to admit that. Because if you say you did and now you say everything was fine because you don't really remember or you didn't do it, and then they come back and they're peritonitic for some reason, med students can get sued. Sorry, hate to say that, but it's possible. So just be careful. Make sure you're honest and be consistent. Something that's really important for presenting, and again, we'll talk more about presenting. We actually have an entire guide we will show you on how to present, which is super cool. And on the back end, shout out, I filmed a little video about how to present. That should be coming sooner rather than later. You can flex your skills on knowing what needs to be said versus what you feel like you need to say. So when I was a 4th year working with 3rd year students, the tendency was every little exclamation point on Epic or your EMR of an abnormal lab value, the med student said every one of them. Now, that's a great way to cover your bases, right? You don't really know what's going on. You want to make sure that your attending knows you looked at the labs, right? But I guarantee you, your attending already looked at the labs, already know what they want to do for the patient, and expect you to do that. So if their sodium, let's say like normal range, right? Like 135 to 145, give or take. If their sodium is 134 and it's been that way for 3 days, you don't need to say that. Like just cut that out and your attending will know like, okay, they know what is important and what needs to be said. So truly for this entire webinar, and this is like one of the biggest pearls that I can give you, is that sub bullet point on knowing what needs to be said. Do not be afraid if you trust in your gut that something is just not important or is just there. You don't need to say it. You don't need to repeat it. So stop the kind of what they call note bloat and all that. You don't need to have that in there. Okay. And if you're wrong, your attending will correct you and it's cool. So you're also going to assist your team, probably the interns, in completing tasks. And then just try to use evidence-based medicine in your assessment and plan. You don't need to necessarily have a citation for everything you do in your assessment and plan, but if there is something really cool that you guys are trying out or you read a study on it or whatever, I have absolutely dropped citations and studies in my assessment and plan. So just make sure you're using evidence-based medicine, which 99.99999% of you are. Now, other things. Again, I've talked about this a couple times, but be a team player, right? The joke is play well with others. So what you want to do is work with your team, the other staff, and the other doctors around to make sure the patient is getting the best care. You can do that by being proactive and being involved. Again, spend that 10, 15, 20, 5 minutes with them in the afternoon, checking in on them, and they will feel so much more at peace. You know, the hospital sucks. No one wants to be admitted, right? But this is something that you really can do and shows you being proactive. Also, if something comes up in your team room of like you hear your residents talking about your patient, Mr. Jones, they need to call IR because they don't know why the CT scan is taking so long, pipe up and be like, hey, I don't mind calling IR. Are you cool with that? And then they'll be like, oh yeah, thank you so much for doing that, Rebecca. So just be proactive, okay? This is also, again, be a helpful and active member of the team. You want to keep track of your patient's functions in the hospital. So again, are they walking around? Are they talking? Are there any acute changes with them? You should know that. Ask your questions. And then I already harped on this enough, but take your time out of your day to get to know your patients. Internal medicine will probably be one of the services where you have the most time to get to know your patients. And as the medical student, that is your job. That is what you should be doing. So take the time to get to know them, not just what brought them to the hospital, but what did they do before the hospital? What is their occupation? Do they have any children? It's okay to ask those questions once you develop rapport. And honestly, I like to talk to them about stuff while I'm in the room waiting for something to load or whatever. So take your time, okay? Presentation skills and styles, right? So on the GIF on the bottom right, it feels like everyone is looking and listening at you. Yeah, some people are going to be typing away. Your attending may or may not be paying attention, but this is kind of what it feels like. And once you do this on any rotation, you will get used to it. So presentation is going to differ attending to attending. I'm sorry. Just like everything in medicine, it kind of differs attending to attending. You really want to balance your comprehensiveness and the conciseness. This is what I talked about earlier, about knowing what needs to be said and when. I want you to be comprehensive and look at every single one of those lab results and think how it affects your patient, but you can be concise, knowing that maybe you note it in your note, but you don't need to say it out loud necessarily. So that will come with time. Where I did internal medicine, it was 8 weeks long. So these are skills you can work on towards the end of your rotation, but trying to incorporate them sooner rather than later is what I would recommend. Now, another annoying thing about being a student is you got to learn the difference on what your boss essentially likes. So how does your resident like it and how does your attending like it? The initial H&P. So one thing that I have always been critiqued on is 50% of the attendings want you to say what happened in the emergency department. The other 50% of the attendings don't really care what happened in the emergency department, which hurts me a little bit as a future emergency medicine doctor, but that's the truth. So you need to figure out if they want certain things said. Certain attendings are cool with you being family history is non-contributory. Other attendings will want you to list the stuff out so they know you, so they know what you asked, okay? How do they want how do they want exams reported? Similar thing. I can get through a quick, comprehensive exam in 15 seconds, but my first time meeting and attending or presenting with an attending, you can bet your bottom dollar I go through every single one of those different subheadings of your physical exam. Start with general, and I work my way down. How are they? Like cardio, lungs, belly, neuro, skin, musculoskeletal, blah, blah, until I can tell that they start kind of losing attention or they realize that I kind of know what I'm talking about. Then you can start to be like, heart, no extra sounds appreciated, regular rate. Lungs are clear bilaterally, belly soft, non-tender, non-distended. Their GCS 15, no neuro status change. Or you can honestly say at certain points, their exam is unchanged from yesterday. This is if you've had that patient that entire week, same attending, they're kind of just stable. You can say that every once in a while. So again, another way that you just have to figure out what is going on. And we already talked about the labs thing. So I'm going to leave this screen up here for about a minute or so, okay? I want you to check the chat because the links are dropped in there if you're on your computer, or you can scan these QR codes. Top left is a blog post and a guide written about everything you need to know on your IM rotation. That is way more in depth than what we're going to do over this and what we have been doing. The bottom right one is how to present on your IM rotation. And again, I encourage you to check back up on Sketchy here over the next couple of months because we're putting together a video of this how to present on your IM rotation, interactive with AI, with me as the narrator. So if you hate my voice, then don't tune into it. But if you like me, then take a look at it. But it's literally shows you a video of how to present if you prefer a video format instead of this. So I'm going to give it just another 15 seconds or so for you guys to click these links, and the links will be in the chat or scan the QR codes, okay? Very good resources. Also gives me 15 seconds to rest my voice. Okay. And again, for the people watching live, one, I appreciate you. And two, drop your questions in the chat. Fill up this Q&A. So I have some people to talk to at the end of this, okay? All right. So some other things, your knowledge growth. You really want to take your time to understand your patient's condition or conditions and what to do about it. Some of my favorite resources is UpToDate, Amboss's Clinical Knowledge Library. There is a book, if you look at it, you can find it online for free, the MGH White Book. This was created by the internal medicine team at MGH or Massachusetts General Hospital. I love this book. It's hyperlinked. It has all the citations. That is one of my favorite resources, to be honest. And then, Sketchy. You wouldn't be here without Sketchy. So take a look here for sure. And then most importantly, your team. Your residents, especially your senior residents or people who have been on service, they probably know these patients. They probably just have an idea of what to do at this stage. So lean on them as well. Now, another scary thing is what to do when you get asked a question on rounds, okay? So answer to the best of your ability. You don't want to ramble and you want to be concise, but you can show them that you're formulating an answer. If you're unsure, it's totally okay to state that. I have many of times been like, I have no idea. I can try to guess, but I really don't know. In that scenario, you want to show that you care about this knowledge. So be sure to write it down or tell your attending, hey, that's a great question. Thank you for bringing it up. I'm going to look it up after rounds because I want to learn more. So different ways to do it, right? And then just don't panic. Yes, there's a quote unquote, it's called pimping, the Socratic method of teaching, whatever, some attendings will take it too far and that's not so great. But at the end of the day, they're just trying to figure out how much you know because we all get evaluated. And I hate a lot of the portions of that, but just don't panic. They're asking you genuinely because they care about what you know and you can really impress them too. So just don't panic. Take a deep breath before answering that question. All right, some other things. Seek feedback. You've probably heard this a million times from your school or whatever, but you really want to seek feedback. Your interns are probably going to give you pretty good pointed feedback. They're probably super busy, but they're the closest to you. So they will probably give you the most. Your senior resident will have seen plenty of med students, so they can help you. Your attendings feedback may or may not be helpful. Some attendings will just write like, oh, you're an amazing student, and then give you 3 out of 5 or whatever. That's the joke that goes around. So 50-50 on how helpful that is, but a really good attending giving you feedback is really important. And then if you're doing like a procedure or how to, changing a dressing or something and the nurse is in there or whatnot, talk to them. Ask them how they like it or how they do it, or if there's anything you can do better next time that you help out. They're not going to put that in an evaluation, but it shows that you care. So I'm a big fan of seeking feedback and working very closely with the rest of the healthcare team. Again, this is your nursing staff, the respiratory therapy staff, going down the imaging techs and people like that. Work together. They're really important people, okay? Now, some pearls. I will also note that all of the gifts in this next section come from The Pit on HBO Max, which is about the emergency department, but it also unveils a lot of the hidden mysteries and things that go on in a hospital. Highly recommend watching if you haven't watched it already. I've seen it twice. So very good and very much so worth watching. Plus Noah Wiley is pretty awesome. So this is my own emergency department twist on this. So I want you to have a system every morning and be consistent. Again, this is when you go, and some electronic medical records have this embedded for you in like a pre-rounding or charting method or feature, but I want you to do the same thing. So typically what I do is I look at their vital signs, and then I look at the overnight note, and this is from like the nursing staff or whatever. Then I look at the note from yesterday, and then I go through labs, imaging, all that type of stuff. That is what I do. in order to be consistent in how I go through it. Now, it might not be the same every day, but I want to make sure I cover everything for my patient. As I said here, nursing notes are clutch, or even just talking to your nurses. So if you pre-round early enough, you can catch the nurses during sign out or catch the nurse and talk to them and just be like, hey, how did Mr. Smith do overnight? That's super good information and almost entirely the subjective part of your note. Again, read the most recent signed note from your attending, and I say bonus here, but it kind of is a requirement. Look at the consult note. If you called a consult for your patient, you better be reading that consult note. Don't just copy and paste it into your note, but read what their medical decision making is, because they're the consultants. You don't always have to agree with your consultants with what they say, and let your attending fight that battle, but you should read these consult notes. So scratch out bonus right here. I'm going to say that's required. So be sure to read the consult notes too. And then don't spend all your time on the computer. Pre-rounding is great. Starting your note early in the morning and having it so you can just make some quick edits, that's great. You have dot phrases for all of that junk. But go see your patient. If something doesn't make sense, lay eyes on them. I know we're all just students, right? But your impression of that patient is really important. So spend your time with your patient. The computer stuff will come second, or it'll come in time in the afternoon. For presentations, so like this GIF shows, sit down if you can during a presentation, or when you're talking to your patient. Learn what your preceptor style is. Some are going to want to do what's called table rounding. So this is sitting down in your comfy chair with your computer in front of you, talking about the patient. Other will do bedside rounds. This is where you go and actually talk about the patient in front of the patient, your entire plan in front of the team, the patient, everything, okay? And then your attending is going to do the exam in front of you, all that good stuff. Again, we already talked about this, but what needs to be said, what should be said, and what needs to be left out. You can have notes. You're going to get the oddball attending here or there that's going to really want you to memorize your presentation or whatnot. Have notes. I don't care if that's on the back of a piece of paper, if you typed it up and printed it, if you have one of those cute like H&P notebooks, which are really awesome. I've done all of these things. So have notes available. You're not always going to have a computer readily available, so you should have notes written down. And then if you can, practice your presentation prior to rounds, especially if your resident has time. That's who you're going to go to primarily. If they're too busy, go in front of a mirror. Talk to your fellow med student. Do something like that, okay? Studying. So the best learning is going to come from seeing a patient with that pathology. So I know that sounds really high and mighty and ivory tower and whatever words you want to throw at me for that, but it really does. You see that patient with acute decompensated heart failure and you walk through it and your attending asks you what the causes are, what meds are you going to do for it, how much diuretics, all that. Guarantee you, you're not going to miss that question again on a practice test or your shelf exam or whatever. So really try to take a look at your patients, read the notes, because this is real life medicine, which is a lot different than what you get tested on. I like to choose at least one topic and do a deep dive daily. So it doesn't have to be one per patient, but you can choose just one if you want to. And I will spend 10, 15, 20 minutes when I get home or in the afternoon really reading up about whatever that is. Maybe there's a new treatment. There's a diuretic, so everyone might know the name Lasix, right? That's what we use for a lot of our patients. There's another one called Bumex or bumetanide. That's a new kind of up and coming. It's being used very often. Read the literature on it. Find out what they actually did their clinical trial on. It's just good to have an idea. This goes back to our evidence-based medicine topic. Again, you're also going to master the balance between studying for yourself and studying for your future patients. This is really difficult. And this is the hardest part of third year, in my opinion, besides like starting a new job every 6 weeks, essentially. You need to study and do practice questions and watch Sketchy and do all this type of stuff. But you also need to learn for your patients, because what we do in the hospital is, I was going to say ever so slightly, but it's kind of fairly different than it's kind of fairly different than what gets tested on an exam. So just be aware of that difference. And then ultimately, this isn't really helpful for the shelf, but when your attending does something, gosh, I am so sorry. My mouse is so finicky today. When they do something of like, oh, I want to do 20 milligrams to 10, or I want to do this instead of that, ask them why. Again, if it's the right time, but ask them why. May not help you on the shelf, but also shows that you care. And you can always ask your resident later why the attending Dr. Johnson did X, Y, and Z. But I love just asking this question, being like, "Hey, I'm just trying to understand your process. Why did you choose this antibiotic over this one?" Make sure it's not a simple something like, "Well, they have an allergy," but ask them why. Now, I debated on having the slide in here or not, and I kept it. So, how to get quote unquote honors. If you go to a school that gives you honors for a rotation, one, I can guarantee you it's not that important unless you are a future neurosurgeon or orthopedic surgeon. But here you go. I'm going to go through this pretty quickly because I think this is low yield for everything we talk about. Be professional, be a member of the team, take an active role with your patients, care about learning. Again, we talked about all of that. Demonstrate that you're reading on your own about your patients. Again, we talked about that. Read up on them. Make sure you read the consult notes. Make sure you read about what is going on. Consider social concerns in disposition plans. So it's really easy as a med student or any clinical student to kind of just be like, oh, like I care a lot about my assessment and plan, but the end goal of that plan is them to go home. So always be thinking about how are you going to get that patient home. You will notice and mention changes in the clinical course. So if they get acutely ill, they look different to you, or I have said this to an attending before, hey, something's just not sitting right with me. They don't look good and I don't know how to describe it, but can you lay eyes on them? They will appreciate that more than you know. So that is a perfectly okay thing to say. And then you're always open to feedback and you're trying to improve as time goes on. Okay, I'm done talking about honors. So something else I want to talk about real quick is the new, I was going to call it an app. That's not necessarily what it is, but the new product by Sketchy called DDX. Essentially, this is real life clinical scenarios between you and a very well-trained AI. It covers your chief complaints, core rotations. They're all interactive. They have like weekly diagnosis games, which are a ton of fun, to be honest. And then you get personalized feedback and hints. So these are some of the cases that they have. There's 40 plus. I'm a QA, like I'm a quality assurance tester for this. And I have easily quality assurance test over 40 cases. So I know there's more than that. This plus is pretty big in here. And they're going to walk you through tons of different things. 18-year-old with fatigue, that's kind of odd. Shortness of breath in a 62-year-old woman, guarantee you're going to see that on the wards. So we also have the diagnosis games. These are like guess the bug, interpret the chest x-ray, board style question vignettes, all of this good stuff. Because it's supposed to be fun to some extent, right? So real quick, I just want to show you what it looks like. So we're gonna stop the screen share here for a second and carry over into my other window. And we're just going to go through it pretty quickly, okay? So I'm going to take some creative liberties here because I want to leave more time for the Q&A. So I'm in here in my Sketchy account, and it says cases up here. I filtered by internal medicine, and I thought altered mental status in a 72-year-old woman kind of right up our alley for what we are talking about today. So I'm going to hit restart just because I already did it. But when I go back here, Maggie Turner is a 72-year-old. She is ever so slightly hypertensive, but everything else looks okay, besides the fact that she is pretty bradypneic. I hate that word. But yeah, she's not breathing super fast, and she has some oxygen support. So let's see what we need to do here. So this is an interesting case, and one of the reasons why I chose this one is it has a different format. So there's a whole bunch of different formats that DDX has. This is one of my favorite, where you get called to see the acutely ill patient. So something changed. You're the student on call, or maybe this is your patient, and the nurse asks you to come see them. This is a totally realistic thing that happens as the medical student. So the nurse states that they were going to get morning vitals, but she was somnolent and less responsive. This is what you got on overnight sign out. She's a 72-year-old female with a COPD exacerbation. She's getting Q4 nebs, steroids, azithromycin, and she's stable on 2 liters nasal cannula. They want you to continue the duo nebs, encourage IS, and reassess in the morning for weaning. That's your pretty standard COPD protocol. So we start with a question. So upon entering the room, you see her lying in bed with her eyes closed. You call her name and she opens her eyes briefly. She utters words that occasionally form short, incoherent phrases. And you ask her to squeeze her hand. She localizes the touch and pain, but can't follow your commands. What's her GCS? So I'm going to save you. If you have GCS memorized, congrats. I don't. I have it roughly memorized from 4, 5, 6. Eyes, motor, and verbal. Eyes, verbal, motor. However, that kind of works. The answer here is 11. And it gives you this whole breakdown, right? We're not just going to answer the question and move on. We have a whole answer explanation that we have. So the more important part is you get called to see the patient. So what you're going to do, the nurse is with you, and you're going to do a focused physical exam, right? So we're looking to get all our key findings here. So thanks for coming to evaluate. Where should we start? So they're acutely somnolent. So I'm going to say mental status or neuro exam. And I'm just, again, typing and talking. So I can already tell I got something up here. They're somnolent. They appears, or GCS is 11, so we were right, but no focal neurologic deficits. They are here for COPD exacerbation. So I kind of care about their lungs. And they're going to ask me what I care about specifically. So auscultation, wheezing, breath sounds, retractions, cyanosis, just listing some stuff, right? We're not going to go through this entire case, but here you go. I just got a couple. So decreased breath sounds, scattered expiratory wheezes. There are no accessory muscle use or intercostal retractions. Does not inhibit any cyanosis. Any disorganized breathing, slowly or breathing inward. Just seeing if she breathes abnormally. Again, I've done this case, so I kind of know what to ask. But she has some paradoxical breathing and a decreased respiratory rate. Now, I can totally ask here, cardiovascular exam, just to be good, what the cardiovascular exam shows, your neuro exam, you can do all that. But I got all my key findings. So now, this is kind of like pre-rounding. They're going to give you, for this specific case, here's their H&P. Here is that entire H&P that you will write on the wards. Here you go. This is what this is. So I could read through all this, blah, 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 but she has COPD. She has inhalers at home, and she uses, she has 2 liters at home as well. She's short of breath. She has sputum. She has a cough. Excuse me. Here's her past medical, and here's what their plan is, right? Which we already kind of knew. Then we go to chart review. Here's all their orders, their med surge, their full code. Here's all their vital signs. Here's what meds are ordered. Labs and diagnostics, nursing orders, all that good stuff, which is really cool. Here's their admission labs, which you can go through. Here's their ABG on admission, which was not great, but she has chronic COPD, so I expect her to be a retainer of CO2. And she was at 90%. Again, COPD, I'm cool with 88 to 92%. I'm cool with that. So your attending's on the way to the bedside. What do you want to do? So I could do bedside PFTs. Guess what? We don't really do bedside PFTs in the hospital. A stat CT head, as a future emergency medicine doctor, I love CT scans, of course, but I don't have enough to get a CT on her right now. This is a decent idea of getting a chest x-ray, especially because it seems like her breathing status has worsened. But I'm probably going to get an ABG first to see how acidotic she is. And so this kind of talks about what we just talked about. Here's the results. So she's definitely more acidotic. Her CO2 is way up. And it looks like she's increased her bicarb a little bit as well. So what primary acid-base disturbance, every med student's favorite thing, I can tell you she's at a respiratory acidosis and she is compensating a little bit for this. Now we get back to talking with the AI. So what are some causes of acute mental status in the hospitalized patient? So infection, urinary retention, stroke, hospital-associated delirium. Again, I could go on and on and on, but the cool thing is that we're going to get feedback. So they're going to give me side effects of medications, metabolic causes, respiratory failure, environmental factors, all of these types of things. So they're going to keep talking to me. So what type of respiratory failure were they experiencing? So they have acute on chronic respiratory, I spelled that wrong, maybe, distress. Again, just going through this. I'm not going to belabor the entire point here. So I know this one says, actually, she has this, but acute on chronic respiratory failure distress. Similar things. I don't know if you noticed this, but her morning labs on her vital signs, she was satting like 98, 99%. That's probably a little too high for her. So I'm going to say hyperoxygenation. I think she's just had a little too much oxygen. And that attending agrees with me, Dr. Rodriguez. And so what is the last thing? What is the best intermediate intervention? I want to switch her over to BiPAP. She needs to blow off that CO2 and get, life better. I can't believe I didn't capitalize that second A or that first A. That's bad of me. So now we move on to the next step. Another little question. We're just going to answer this and move on for time. Here is her hospital course in her management. You will have other cases where they will ask you what meds you want to put them on, what labs you want to get, what imaging you want to get. You have to interpret the labs and imaging. Again, this is just one example of what it looks like. She stays in the hospital for 4 days. She gets weaned down and is stable for discharge. I have another question here. This one's a little question heavy, which I think is okay. We have some key points, and then we have our learning points. And guess what? We have references all down at the bottom for all of these. And then, because it's sketchy and because it's fun, I get a final score. So other people have scored 74%. All of us today did it and got 100%, and we only did it in 7 minutes. Now, that might be because I've done this case multiple times, but I also think it's because you guys are just that smart. So that's what DDX looks like. So we're going to go back to the slides to finish up here. As my cat paws at the door to try to get in. We're going to come here. All right, so I just want to note, since we talked about DDX, I want to talk to you about how you can use it efficiently. So I like to filter it by system or by rotation, and you can find specific chief complaints. That being said, you can just do it randomly and do a whole bunch of different questions, and that's fine too. It's going to reinforce what you see and apply your book knowledge. I really think this is your number one OSCE prep resource. Now, seeing patients obviously is number one, but if you go to a school that has you do OSCEs at the end of each rotation, this is going to help you prep for that by knowing what to ask, what exam maneuvers to do, and what your assessment and plan should be for those specific chief complaints, which are always pretty broad in OSCEs. This is your go-to here. Again, what I kind of talked about already, fatigue, syncope, palpitations, go through these vague chief complaints for whatever rotation you're on and practice building your differential and your assessment and plan for them, because that's kind of what your OSCE is going to be like. And then every once in a while, we just don't see everything that is on our case log or our OSCE or the shelf or whatever. So go through the cases that you never saw a patient with to make sure you at least did something of figuring out how to talk to them, what exam maneuvers to do, what to ask, X, Y, and Z, okay? So now this brings us to the Q&A portion. And I'm actually going to close the slide deck for now. All the fun stuff while we do the Q&A, we're going to raffle off for the giveaway winner. And I also want to note that we have a 25% off code going on right now, webinar 25. I get zero kickback from this, but I'll give you my Venmo if anyone wants to Venmo me. I'm totally kidding, by the way. I have no financial disclosures. But here's the 25% off code that expires end of day 6/6. So end of day on Friday. This is pretty good for you if you would like to purchase that. So while they get the giveaway set up on the back end, I want to thank you for your time and your attention. If you're watching this as a recording, drop a comment, anything like that. Otherwise, I'm going to end my screen share here. And I encourage the people who are live, drop questions in the chat, although preferably drop them using the Q&A feature if you are able to. And Brenna and Noel, please feel free to interrupt me with the giveaway at any time. I did see a question as I was going in here in terms of how to, I can't find the question anymore, but I remember it. This is how to order your physical exam. So I go in the same order that my physical exam is on my note, essentially. Now, yes, it's like general. Let me step back for a second. Actually, so I go in a similar order that I have on my note, but I go top to bottom. So I go with how they generally are appearing. And then I go with, vital signs, general appearance, and then anything in the face, if need be, heart, lungs, belly, anything kind of urinary or GI or whatever is in there. And then if I need to, MSK, and then I end with neuro. So yes, the brain is up here, right? But I do that one last. And I kind of just run through my physical exam that way. I have a very routine physical exam I have as a dot phrase, one that I know pretty well that I trust in how I use. So I tend to just repeat that roughly for presentations or my notes. So that's the answer to that question. But again, if anyone else has questions, I encourage you to use the Q&A feature here and don't hop off until the giveaway is conducted. But yeah, hit me with questions. So there's another one in the chat. Are there different specialties for DDX, like IED versus neuro? Yes, there are. So they're kind of broken down right now by rotation, but you can definitely filter it by specific things. One of their weekly kind of games that they do is like guess the bug. So I'm a little rough on my bugs and drugs. It's been a while. I've actually been doing them to get more practice, to see patients again. So that's something that I like. And then are the cases always inpatient or are there outpatient encounter simulations? There are both. There are inpatient and outpatient for sure. So you get a wide mix of both. Again, the one case that I showed in this webinar is a pretty specific one where you get called for an acute status change in a patient. You're going to have other ones where you're in the outpatient clinic and someone says, I've had a rash for 2 months. And then you will work through everything from top to bottom for that. So again, I just wanted to note that I showed you kind of one of the one-off cases, but I feel like it's very good in how it's laid out as it correlates to the internal medicine rotation, which is what we're talking about today. And it looks like Max, or Brenna, if you want to do it, Max is the winner of the 6 months sub. So congrats.
Yes, congrats, Max. We'll reach out to get you all set up and everything. But thank you so much, Connor, for running through this IM webinar. Again, people, we still got about 10 minutes. If you want to drop any questions in the chat or in the Q&A, we'll be here. In the YouTube chat. Let me take a look.
I will rely on you for that, Brenna. And while you're pulling that, I'm going to, so there's one in here, on days where your preceptor is on admissions, what does that day look like? Or how does it differ from traditional rounding days in a specific unit? Awesome question. That's super in-depth. So the way that it worked at my institution was we had short call, long call, no call, or no call, short call, long call. So no call was no admits. That is, you round or you pre-round, you see your patients, you get things tidied up, and you're home by like 3 or so, which was really nice. Short call days for me were about 5 p.m. So we took some admits, but not the late ones, in which really that was an afternoon thing. Your senior would know what admits were coming down the pipeline, but we would typically see them after rounds unless they were like incredibly ill or right next door to one of our patients. And then long call is the same thing. It's just a longer day and you take more of the admits. You will never be signed out a patient of another teams that you need to follow. That's for your residents, right? But on days where we're specifically doing admissions, you're going to focus more in the afternoon on collecting a brand new history and physical. So there's probably going to be a way more in-depth template, dot phrase, whatever, for that admission history and physical. And so you're going to spend extra time. This is your family history, your social history. What do they eat? Do they exercise? Are they religious? All that type of stuff. Whereas your more day-to-day notes are, again, presentation is a bit more in like the SOAP format. But once you have a patient for a couple days in a row, you kind of know what you need to say. And so on admit days versus like a rounding unit that is pretty much just consults only, you're going to round in the morning, and then the afternoons are for patient care tasks, so calling consults and all that, and seeing your new admits. Likely you'll have another med student with you, so you might bounce back and forth, or there's probably an admit or two that you won't take just because they're too complex or they're not so nice of a patient, that type of thing. But admit days, your number one thing is going to be doing that admission history and physical. How do you suggest dealing with patients who tell you one thing during pre-rounding and say a different thing to attendings during rounds? I have no answer for you, wonderful YouTube participant who asked this question. There is no good answer. It hurts every single time. I lose a little bit of my soul every time that happens. Now, the way you can think about this is that if you know for a fact you asked the question and you brought it up during your presentation and all of that, and the patient then said something different, maybe it's new. Maybe it is something that has happened since you pre-rounded and now they're the last patient on your list. Things can change definitely over time. Sometimes patients are forgetful. Sometimes they think, even, again, not for sexism here, but males, females, any gender really, they can think we're nurses. Some people don't really understand what a medical student is, or a PA student, or an NP student. They don't really understand what that is. So maybe they're just saying things to get you to leave the room, or maybe it's not really happening, or they don't really trust you. Again, there's a lot of sad answers for why this happens, but I like to just know, like, or I joke with my attending when I leave the room of like, hey, they 100% told me they had abdominal pain when I saw them this morning, and now it's chest pain. And so I just like to call it out and be like, I asked, this is what they told me, and they'll just joke and laugh it off. So don't make a big deal out of it, especially not in front of the patient, unless you're absolutely concerned, and be like, hey, this is, you told me this morning that you had more belly pain. Is it more your belly or your chest? Like, that's a good inquisitive question. You're not saying the patient is a quote unquote liar or anything like that. But you will never stop dealing with, even as a resident, honestly, probably as an attending, it feels different in some nature, but you're never going to stop dealing with this idea that patients are going to say one thing to one person and then to a different person. We all have different personalities, and we all have different ways we work with patients. So if I had an answer for you directly of how to deal with this, I would sell it and be able to never have to pay rent ever again. Do you ever watch a sketchy video before interviewing a new patient? So I didn't have time, I'm just being open and honest with you, to look at the video specifically before going to see a new patient. That being said, Sketchy isn't just videos. So Sketchy has these wonderful flashcards now that you can go through. They have different little things. So if you prefer the Sketchy format, if you have time to watch the video, heck yeah, do it. That's awesome. But you can also just search Sketchy and see if what you're looking for has something a little bit smaller or more digestible in that time frame to go through. But what I absolutely would do is, in the evening, in the afternoon, when things are calm, then I go back and watch the video. So before I see the patient, that's going to be a quick browse of Sketchy if they have something, maybe up to date, maybe Amboss, maybe Googling pertinent physical exam maneuvers for someone with left leg pain, right? Like, that is something you can totally Google versus other things where I need to really sit down and digest what I'm doing, which I probably do after the patient is seen. But I guarantee you there's probably people who pull that video up and have the time in the elevator to watch it before they see the patient. I neglected my Q&A. All right, we're going to switch over to Q&A. Do you have any good tips for foreign students for us? Unfortunately, I don't have a ton. It depends on where you do your rotation or your observership or whatever they like to call it. Really just try to show what you know. Again, this is the same thing of like, you don't need to be a quote unquote gunner or anything like that, but I definitely want to see you flexing your knowledge of like, you've seen heart failure before. You know what meds are going to be on. You don't necessarily have to know the dose, but just have a rough idea of what meds they go on, what do those meds do. So really my advice for foreign students is the same as United States-based students. Just try really hard on your rotations. Don't be, too much or anything like that, but just genuinely care about your patient and care about learning, and that will serve you well. In regards to hours, do medical students do night shifts and day shift changes within each core rotation? So it really is school dependent. So for my school, we did 8 weeks of internal medicine, 4 at the VA and 4 at our home hospital. We did not work nights. That is not something that we did. That being said, I know plenty of other students at other schools that will do night shifts. They will take call. So they will be there overnight. They will have 24-hour call. They will work 6 days on, 1 day off, all these different types of things. You may definitely bump into other med students who are coming on for nights or whatever, which I think is kind of cool. You do your own little mini sign out. You probably shouldn't be expected to take like, let me clarify. You shouldn't, if there's like a intern covering the patient and you come on at night, like the odds of you picking that patient up and them being yours is a little bit low. Or if there's another med student like taking that other patient. That being said, it does help if it's like a med student patient. So this is like your bread and butter chest pain, COPD, heart failure exacerbation, whatever, cellulitis. Those are pretty good learning cases. And so it's not rare for you to pick that patient up from another med student, but you're always going to have a physician, namely a resident, who is mainly on that case. There are definitely other rotations like OBGYN loves their nights, EM loves nights. A lot of the console-based services I never worked any nights on, which was really nice. But surgery, for sure, you'll work some nights. It's all just really school dependent. But again, I think it's kind of cool to come in and see your fellow med student and they go home and you're there, depending on how close you are with your class. All right. As we finish up, we got 1 more minute. If anyone has any last minute questions, you can drop it real quick and I'll try to get it done. Otherwise, I appreciate you guys being here. I do want to subtly shout out, I have my own website. You can look me up. I have an Instagram too. If you like me, I like to offer a lot of free resources as well, which is why I do a lot of this with Sketchy, because this is a free resource. So I always appreciate my Sketchy friends for giving me the platform to talk to you all for the last hour. I hope this was helpful. If you're watching this recording, drop a comment. Let me know what you liked. If you have any comments, I will try to take a look and answer them. But I appreciate you all. And then the last question is, are there opportunities for students to get involved with the Sketchy team and testing new things? So Sketchy on their website, or will send out every once in a while that they are looking for beta testers or whatnot. You can also sign up to be a Sketchy ambassador, which has a really cool like type form. I don't know if the wonderful Sketchy team can drop that in the chat. But you can sign up to be an ambassador for your institution or your university, which is another great kind of inside access way to really help out the Sketchy team, because that's what I did. I emailed them 4 years ago asking if I could set up a discount for my school, and now I do some work for them and have this awesome, can't see it with my head, let me turn somehow, awesome little Sketchy diagram that they created for me. So I love Sketchy and I love everything that they do. So you can totally find their ambassador form, which is in the chat right now. They are wonderful people, highly recommend. And they're letting me stay on as a resident, which makes me really happy too. So again, thank you, Sketchy. I appreciate you guys. Thank you, everyone watching. And hopefully I'll see you for the next one.
Thanks everyone. We're gonna close it out and we'll send those links in the follow-up email so you have them along with the coupon code. Thank you, everyone. We'll see you next time.